Hi, this is Brian Wormers. I'm going to be talking about malnutrition today for medical surgical nursing. So our main learning objectives would be talking about nutritional recommendations, how to do a nutritional assessment, looking at pathophysiology, signs and symptoms, and evaluation related to malnutrition and conversely obesity. So the nutritional standards that we're going off of are the USDA MyPlate, which is the dietary guidance for Americans. And you can kind of see that here, fruits, vegetable, grain, protein, and dairy, and how much of each you should have. But take into account that there are cultural awarenesses with this, and you will study that more in Trinity if you have not already. And then there are geriatric considerations about the food preferences that they may have. So in doing a nutritional assessment, of course we want to talk about patient history with this. So what are their metabolic needs? How much are there any special considerations related to chronic disease, alcohol abuse, surgery, weight loss, anything like that? How active are they throughout the day? What's their eating behaviors and recent changes? When do they eat? How much do they eat? Any problems with difficulty in chewing or swallowing? What medications might they be on? Are they on anything to help stimulate their appetite like periactin or megase? Is there anything that's used to, suppress that appetite that they're taking? Any multivitamins that they're taking, or iron or supplementation? On the assessment, you can look at their height, weight, ability to eat. You can look at anthropometric measurements, looking at height, weight, BMIs, skin fold, those type of tools to kind of look and see how they are doing on keeping that up. Look at clinical manifestations, from head to toe. We can talk about hair. How does that look? Is it frail, or is it nice and full and glossy? Are their eyes sunken, or are they, hydrated well? Oral cavity, is it pink, moist, or are they dehydrated? What's their nail beds look like? How's their musculoskeletal system? What's their neurological system like? All those are key factors with this. Labs that we can do for this would be, an H&H. We can look at serum albumin. We can look at thyroid, because, maybe they're not eating good because their thyroid is off. Cholesterol, electrolyte imbalances, lipid proteins, and lipid panels, all those different types of things for nutritional assessment. For malnutrition, some of the things that this will impact will be the functions of liver, heart, lung, GI tract, immune system. All those will decrease if you're malnourished. Other complications, cachexia, which is muscle wasting, decreased activity tolerance because you don't have the energy for it. That ties in with lethargy. Intolerance to cold because you don't have any body fat. Edema because you're getting third spacing, related to lack of proteins and shifting of fluids within your body. You get dry, flaking skin, poor wound healing because, once again, no protein, and possibly death. And electrolyte imbalances can definitely play into this. Long-term nutritional disorders that we're concerned about would be cancer, kidney disease, chronic neurological cases where they maybe aren't alert enough to eat, marasmus with their calorie deficient, or kwashiorkor when they are calorie and protein deficient. Also, eating disorders, anorexia nervosa and bulimia, and those are both very difficult cases to treat. But in nursing, it's quite possible that you're going to see that, and that can be part of your nutrition. Total enteral nutrition, so this could be a couple of different ways. So we could talk about nasogastric, nasoduodenal, so bypassing the stomach and going right into the intestine. We can talk about G tubes, J tubes, PEG tubes. So there's lots of different ways that we can feed people, not just orally, but with different tubes in different places. Refeeding syndrome. This is a very deadly situation that can happen if somebody's malnourished and all of a sudden you start feeding them again. What happens is the insulin production resumes, and then it takes up the glucose and electrolytes from the bloodstream, but this depletes serum levels, especially like of your potassium, and it can lead into arrhythmias, and it's deadly. So if somebody is severely malnourished, we can't just give them a big bacon cheeseburger and fix them, because that actually might hurt them more than it helps them. Of course, complications would be is if the tube is in the wrong spot. That can lead into aspiration or peritonitis depending on what tube and what place. Abdominal distension, nausea, and vomiting if they're not handling it well. Food and electrolyte imbalances, and we kind of talked about that before, but hypophosphatemia, magnesium, potassium, and calcium are all major considerations with this. Parenteral nutrition, so when they can't use the GI tract, then we start using the IV fluids. And so we can do partial or total parenteral nutrition. And so this is commonly called like TPN and lipids. And it's used to treat fluid imbalances, electrolyte imbalances, and for maintenance. On the opposite end of this is obesity. So this is being overweight compared to the standard. So overweight is 10% greater than ideal. Obesity is 20% greater than ideal. Morbid obesity is 100% above ideal body weight. So complications of obesity are, well documented and very numerous, unfortunately. But it can include hypertension, hyperlipidemia, coronary artery disease, stroke, peripheral artery disease, metabolic syndrome, obstructive sleep apnea, obesity, hypoventilation syndrome. And the obesity hypoventilation is very similar to sleep apnea. Other things, depression and mental health problems have been correlated with that. Urinary incontinence, cholelithiasis, gout, chronic back pain, early osteoarthritis, and decreased wound healing are all complications of obesity. So to manage this, of course, we're going to try and do diet programs. So it's caloric balance, so increase activity, decrease calories, and trying to have a negative caloric balance for a period of time. So we work on that with nutrition, we work on that with exercise. We can substitute and we can use meds such as these wonderful things here. Behavioral management is a wonderful tool for this because oftentimes we eat because we're hungry, or not because we're hungry, but because we're sad or we're lonely or we're bored. So the behavioral management of this is quite complex but can be very beneficial. Otherwise, complementary and alternative therapies such as acupuncture, acupressure, hypnosis have worked in some patients. And if none of these are working, then we can advance into a surgical management. We can do liposuction, take some of the fat cells out of the body. But more commonly, what we should probably be doing is working within the field of bariatrics and getting them on board. And either doing a restrictive gastric banding type of situation, otherwise a gastric bypass. And so we kind of sew this up and it goes right from here into the tube, and you're bypassing the stomach for the most part. So considerations after bariatric surgery include airway management. Of course, ABCs are paramount with this. We are concerned about pain management because it was surgery and it does hurt. Patient and staff safety. Fall risks are very real, and these patients can be quite heavy sometimes, so we worry about back and the difficulty of that, as well as the special equipment needed, different lifts, different assisted devices, beds, chairs, those type of things. We do want to care for the NG tube, make sure that that's in place and applicable. We want to check for leaks. Anastomotic leaks are when you're connecting those two different things up and you sew it together. We're looking for leaks at those places. We can look for a sequential compression hose, heparin, try and prevent any blood clots. We're doing skin assessment. We're looking for removing that urinary catheter as soon as possible to try and prevent UTIs. Getting up and ambulating as soon as possible. Monitoring that abdominal girth to see if we're making an impact. Often giving small feedings. Like by small feedings, we're talking about letting them have 10 to 15 cc's of fluid and ramping that up slowly. They will not be getting a steak supper right after surgery because that would wreck all the sutures and not help things. And then, of course, observe for signs of dumping syndrome, and basically that's going to be diarrhea, where things move too fast through the GI tract and they get diarrhea, and then they're going to get malnourished because of that. So that finishes this lecture on malnutrition and obesity and nutritional assessment. If you have any questions, please contact your instructor.